Hello everyone, I am Dr. Richa. In this video, we will talk about antihypertensives. So, these drugs, antihypertensives, as the name suggests, they are used to decrease the blood pressure. But when it becomes a need to decrease the blood pressure, so that occurs in case of hypertension. Okay, what is hypertension? Hypertension is sustained increase in blood pressure and so much increase that it can be damaging to the organ. So it can cause end organ damage. End organ damage means the end organ to which the blood supply is going on. And if there is too much blood pressure, then because of that there can be end organ damage. So what is hypertension? Sustained elevation of blood pressure which can lead to end organ damage over time, or it can be so much high that it can lead to end organ damage very fast. Okay, so how much is that blood pressure? So we consider normal blood pressure as less than 120 by 80 millimeter mercury in adults. Less than 120 by 80 millimeter mercury. That means systolic less than 120 millimeter mercury and diastolic less than 80 millimeter mercury. If the blood pressure becomes more than 130 by 80 millimeter mercury, then that is considered the blood pressure at which the drug treatment should be started. Okay, before these guidelines was bit higher. It was if the blood pressure became 140 by 90 millimeter mercury, if it becomes more than that, then the drug therapy has to be started. But now we consider that if blood pressure is more than 130 by 80 millimeter mercury, then drug treatment has to be started. So the goal of the treatment is to maintain the blood pressure, that is the target blood pressure should be less than 130 by 80 millimeter mercury. And in between, that means the systolic blood pressure, if it is between 120 to 129 millimeter mercury, then that is known as elevated blood pressure. Okay, so at this blood pressure it is recommended to put some lifestyle changes so that the blood pressure doesn't become greater than 130 by 80 millimeter mercury. Okay, so now straight moving on to rationale for this therapy. Okay, so for that we should know little bit physiology. Blood pressure is governed by two determinants. We said that blood pressure is systolic blood pressure and diastolic blood pressure. So in physiology there are two determinants of blood pressure. That means two physiological variables which will determine how much blood pressure is, and these are cardiac output and total peripheral resistance. Cardiac output determines systolic blood pressure. That means more the cardiac output, more will be the systolic blood pressure. And total peripheral resistance determines diastolic blood pressure. That means more the total peripheral resistance, more the diastolic blood pressure. So that is the very fundamental which we talk about. But what happens in body when there is increase in cardiac output and there is increase in systolic blood pressure? In that case, over time what happens, ultimately the TPR also increases. Okay, so this concept we don't tell in first year generally because little complicated, but Guyton has given one proper flow chart for this, that whenever there is change in the cardiac output, ultimately it will lead to change in the total peripheral resistance, and that is the main consistent factor which will affect the blood pressure. Fine, so this concept you remember, because generally we will see that all of them target this total peripheral resistance. Yes, there are the ones which are going to decrease the cardiac output, but over time ultimately they will also affect the total peripheral resistance. Okay, now this cardiac output, how it increases? So this is the determinant of blood pressure, but what are the determinants of cardiac output? Okay, so cardiac output increases when heart rate increases, when stroke volume increases. Heart rate into stroke volume is cardiac output. Okay, when preload increases. Preload is what? Preload is the load which the heart has to pump. Okay, so that means the venous return which is entering into the heart. So this is venous return. When venous return increases, then preload increases, and this also causes the increase in the cardiac output, because if incoming to the heart is more, that means outgoing should be more. It should not collect there. So that is venous return increases, if that also increases cardiac output. What are the factors which affect the venous return? If blood volume is more, then venous return will be more blood is going to the heart. Yes, there are short-term other factors are also like walking, respiratory pump, all that. But when we are talking about hypertension, sustained elevation of blood pressure, then those short-term factors which affect the venous return, we don't talk about them. Okay. So blood volume affects venous return, which increases the preload and that increases the cardiac output. Now, these heart rate, stroke volume, they are also affected by sympathetic activity. Okay, so more the sympathetic activity, more there will be increase in heart rate, more stroke volume, and hence more cardiac output. Also, sympathetic activity increases the venous return because it leads to constriction of the veins. So that also occurs and that also leads to increase in the cardiac output. Understanding? So fundamentally we are reaching to yes, that increased sympathetic activity will lead to increased blood pressure. Next one, total peripheral resistance. What is that? Total peripheral resistance is the resistance to blood flow by the blood vessels. And that happens when arterioles are too much constricted. Okay. Now these arterioles, they are supplied by nerves, that is the sympathetic nerve. So I have put one plus sign here also. So this sympathetic activity is going to stimulate the arterioles causing vasoconstriction. So that is also going to lead to increase in the total peripheral resistance and that is going to increase the diastolic blood pressure. So simple, anything which causes vasoconstriction, decrease in the diameter of the blood vessels, that is going to increase the total peripheral resistance and hence the blood pressure. Okay, so that was about the nerves which are affecting the cardiac output and the total peripheral resistance. But we have very important system, that is renin angiotensin aldosterone system, or known as like this also renin angiotensin system. So this also, if increases the angiotensin 2, if there is increase in the release of renin, there will be increased formation of angiotensin 1. Renin actually converts angiotensinogen to angiotensin 1, and ACE, angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2. So when there is more angiotensin 2, that leads to increase in the absorption of sodium and hence of water from the kidneys. Actually, it happens directly also and it acts by releasing aldosterone also. Okay, so this one extra A here, renin angiotensin aldosterone system. Angiotensin 2 causes release of the aldosterone, which in turn causes increased sodium reabsorption and increased water reabsorption from the kidneys. So this leads to increase in the blood volume, and we have seen that how blood volume increases the cardiac output, right? Now, next is angiotensin 2 directly also causes vasoconstriction and that leads to increase in the total peripheral resistance and that leads to increase in the blood pressure. Fine. So, this is the fundamental of the determinants of blood pressure, cardiac output and total peripheral resistance, and the factors which are affecting this. Now, moving on to antihypertensives. So these antihypertensives, actually we see that they act at various levels of this flow chart. Okay, so we have calcium channel blockers. One, calcium channel blockers, what they do? They will block the calcium channels as the name suggests. Okay, and in the heart and in the blood vessels we have calcium channels. This detail how calcium channel blockers act, I have already dealt in another video on calcium channel blockers, so you can watch that. Fine. So yes, calcium channels are present in the heart and in the blood vessels. Now when these calcium channel blockers block the calcium channels in the heart, this will lead to decrease in the contractility. Okay, heart will contract with less force. And when it blocks the calcium channels in the vessels, then less calcium is going to enter into the vessels, and again the contraction in the vessel wall is going to be less. If the vessel wall contraction is less, the muscular layer is there. If that is less, then there will be vasodilation. Understanding? So we have two types of calcium channel blockers, that means the non-DHPs and dihydropyridines and non-dihydropyridines. In non-dihydropyridines we have the verapamil and diltiazem, and the others, that is nifedipine, nicardipine, all that come in CCB. For antihypertensives, for treatment of hypertension, we have one very important drug commonly used is amlodipine. Okay, so CCB is blocking the calcium channels in the heart and in the blood vessels. Non-DHPs block both of these calcium channels. DHPs are mainly acting on the vessels. Remember that. Okay, non-DHPs act on both. DHPs act only on the vessels, right? So where in this schema they are acting? You see, non-DHPs, they are because they are decreasing the contractility, stroke volume is going to decrease. So they are acting here. Then non-DHPs plus DHPs both are acting on the vessels. So they will cause vasodilation and they are affecting here, right? So that is CCBs. Next is RAS inhibitors, renin-angiotensin system inhibitors. So what these are? These are ACE inhibitors, that is they block this enzyme, angiotensin converting enzyme, so that less angiotensin 2 is formed, or they are angiotensin receptor blockers. That means angiotensin 2 will form, but they are blocking the receptors of this angiotensin 2. So angiotensin 2 will not be able to act, right? So it will not be able to cause vasoconstriction and it will not be able to cause increase in the blood volume. Then we have renin inhibitors. Renin inhibitors, these are newer drugs. Okay, so they block renin so that here angiotensin 1 itself is not found. Okay, here one thing I forgot, that sympathetic activity also acts on actually beta 1 receptors which are present in the JG cells in the kidney. Okay, and this causes also release of the renin, right? So this is important because we will talk about beta blockers as well, right? So here we were talking, yes, RAS inhibitors. What are the various drugs? ACE inhibitors, ARB and renin inhibitors. Third drug is diuretics. Diuretics, we have three types of diuretics which can be used in hypertension. One is thiazide diuretics, the other is loop diuretics, the other is aldosterone antagonist. Okay, they block the aldosterone receptors, the mineralocorticoid receptors. Okay, so we have seen, you see here we have said renin angiotensin aldosterone system, aldosterone is there. How these diuretics act? So diuretics, the thiazide and loop diuretics basically cause diuresis, that means loss of the fluid from the kidneys. Okay, so they are going to decrease the blood volume. Understanding? So decreased blood volume ultimately will affect the cardiac output, and I told ultimately over long term this TPR is going to decrease, right? Aldosterone antagonist, again this is going to interfere with this blood volume quantity. It is going to decrease the blood volume, right? So that is diuretics. Three classes we have seen: calcium channel blockers, RAS inhibitors and diuretics. Remember that these three classes are the first line drugs for the treatment of hypertension. So when we are trying to treat the hypertension, first we have to think of these three drugs. Understanding? Then if these drugs cannot be given, then we have to think about other drugs. Okay, so what are these other drugs? We have sympatholytics. Sympatholytics. Lytics means breakdown, and sympatholytics. So they are going to break down the sympathetic activity. In this we have different classification. We have beta blockers, alpha plus beta blockers and central sympatholytics. Okay. So beta blockers, as the name suggests, they will block the beta receptors. And where are these beta receptors present? These beta receptors are present in the heart. These are beta 1 receptors. So sympathetic activity, when it releases norepinephrine, it acts on this beta 1 receptors which are present in the heart. Okay, so this will be blocked, and also these will be blocked, right? Because JG cells is having beta 1 receptors, that will also be blocked. So blood volume will also be affected, because ultimately renin releases less, renin-angiotensin system action will be less, right? So that is beta blockers, the mechanism of action. Alpha blockers, how they will act? Alpha receptors are present on the blood vessels. Okay, here we have the alpha receptors. Beta receptors on the heart, on the JG cells in the kidneys. Alpha receptors, they are present on the blood vessels. Okay, when these alpha receptors are stimulated by the sympathetic activity, I told you sympathetic activity also leads to vasoconstriction. So that norepinephrine is acting on the blood vessels on these alpha receptors and leading to vasoconstriction. So if we block these alpha receptors, then vasoconstriction will not occur. There will be vasodilation and there will be decrease in total peripheral resistance. Understand me? So beta blocker, alpha blocker. Beta blocker on heart and kidney, alpha blocker will act on the vessels. Alpha plus beta blocker, it will act on both, right? Central sympatholytics. What are these central sympatholytics? Actually, they will decrease the sympathetic outflow. That means the activation of the sympathetic nerves itself is going to decrease, and these are basically alpha 2 agonist. Alpha 2 agonist. Okay. Now, what happens? Let me just delete this flowchart because we are almost done here. So I just want to tell how this central sympatholytics act. Okay. So what happens that, say, this is the presynaptic neuron and this is the postsynaptic neuron, right? Now, sympathetic activity has preganglionic fibers and postganglionic fibers. Okay, all the autonomic nervous system nerves have preganglionic fibers and postganglionic fibers. Now, preganglionic fibers release a neurotransmitter that is acetylcholine, right? Now, this postganglionic fiber, here it releases the norepinephrine. All the preganglionic fibers, whether it is cholinergic or adrenergic, it releases acetylcholine. Postganglionic fibers releases norepinephrine, right? Now, this postganglionic fiber has a receptor that is alpha 2 receptor, fine. So here there will be a receptor that is alpha 2 receptor. Now this norepinephrine which is released, it will go into the circulation, it will act on various organs. So in our case, we are talking about it will act on heart, it will act on kidneys, and it is going to act on blood vessels. But it also goes and acts on these alpha 2 receptors. And what they do, these alpha 2 receptors actually cause entry of some negative ions. Negative ions. Okay, say chloride. So they are decreasing the potential here such that the vesicle fusion is going to decrease. Calcium entry will be less. Everywhere you see that when we are talking of decrease in the vesicle fusion, there will be actually what is the mechanism? That it is going to decrease the potential. Hence, there will be decreased opening of voltage gated calcium channels. This will lead to decrease in the fusion of the vesicles to the membrane, and hence if there is decreased fusion, there will be decrease in the release of the norepinephrine. In this case, it will be norepinephrine. Okay. So, if alpha 2 agonists are given, that means any drug which is stimulating these alpha 2 receptors, ultimately what will happen? It is going to decrease the norepinephrine release. Understanding? So, that is central sympatholytics. It is not affecting like the effects of these. At the organ, it is not acting. It is decreasing the norepinephrine release only. Fine. So that is central sympatholytics. That is alpha 2 agonist. Okay. Then we have the vasodilators. In vasodilators, we have arterial dilators and arterial plus venous dilators. Arterial, I told you that when they constrict, what happens? Peripheral resistance increases. Actually, arterioles are known as the resistance vessels. Okay. So there are arterial dilators. Basically, we have hydralazine which dilates the arterioles. So that is going to decrease the peripheral resistance. Fundamental. Whenever there is arterial dilation, there will be decrease in the peripheral resistance. And next we have arterial plus venous dilator. We have nitroprusside in this. Okay. So that dilates both arterioles and veins. Veins, if they dilate, what is going to happen? Arterioles we saw. Veins, if they dilate, what is going to happen? That means the capacity of the veins is increasing. Veins when constrict, it causes the return of the blood to the heart. When they dilate, now the blood is accumulating in the veins. Okay, that is known as venous capacitance. That is going to increase. Venous return to the heart is going to decrease. If venous return to the heart decreases because blood is in the veins, now it is not coming back to the heart. Less is coming back to the heart. So cardiac output is going to decrease. Understanding? So these are the 5 different classes of antihypertensives. calcium channel blockers, RAS inhibitors, diuretics. These are the first line drugs. In this also, in RAS inhibitors, these are the first line drugs, ACE inhibitors and angiotensin receptor blocker, not the renin inhibitors. Okay. Then we have sympatholytics and vasodilators. In sympatholytics, we have beta blocker, alpha plus beta blocker, and central sympatholytics. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and do subscribe to the channel Physiology Open. Thank you.